September 30th, 2021, thank you. We are getting ready to perform spine surgery, and we're broadcasting live to you so you can watch it and ask questions, be part of the surgery. Our patient is here to have 2 herniated discs in her neck fixed, and she's already had fusion done in the past on her neck. And this is a case where she's developed what's called adjacent segment disease with herniations above the fusion. And so we're going to try to fix those for her without doing more fusion. Is she completely relaxed?
Yes.
All right. So I'm pushing and she's flexing. I don't want her to flex. I need her. Well, she's not flexing from a muscular standpoint. She's just flexing because I'm pushing. So I need you to hold her head in extension and keep her from flexing. All right, so we're gonna, our patient's asleep and intubated, and like I said, they've had a fusion already done at 5, 6, and 6, 7 shot. I can actually feel the metal plate right now, and I gotta be above the metal plate. Shot. All right. So I'm working my way up to gain access. To her spine. Shot. 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 Let's get an AP quickly. So this looks pretty good. Shot. All right, lateral. Again, we're aiming for just above her plate, because that's the first disc we're going to fix. It's also the worst. Shot. 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 Let's get an AP shot. Quickly. That looks pretty good. Back to a lateral. Could be a little more towards me. Shot. 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 And let's get an AP. Go ahead. It's a quick AP. Back to a lateral. The plate's on a little crooked. Shot. Shot. All right, so we're starting to get in there. Coker. Let's get an AP again just to make sure we're in the middle. You okay up there? I need you to give me a little inline traction, which is extension and pulling. So kind of rocking her head back. There you go. Shot. All right. Sorry. Again. AP. All right. A little bit off to the other side. Take that. Lateral. Lateral. You're flexing her. I don't want her flexed. I need her extended slightly. Shot. That's it? Is that it?
Yes, sir.
Shot. Shot. Hold on. Just dealing with the top of the plate. Shot. Let's try, hold on. Shot. Shot. Let's try an AP now. Feels better. Let's see if it looks better. Shot. That looks better. All right. So adjacent segment disease is tough because you have obviously the metal that the other surgeon put in. Phew. All right. Shot. Now let's get an AP view. Now we got some time. So I had to press down, and right above her prior fusion, I could feel the actual plate with my fingers. And using the X-ray, that's perfect. It's right in the middle. You can see how the plate is angled. I did not put that plate in. That was done by another surgeon in Texas. Our patient travels here from Texas. So we are in the 2, 3, 4, 5. Everyone agree? And there's a giant disc herniation here. So we call this adjacent segment disease when a patient has a herniation that is above or below a prior surgery or fusion. You can relax now. Whoever's working over there. Yeah, we're in like Flynn, we're good. So now we're going to do our discogram. Our patient is not awake. Can we just make sure blood pressure is good? Let me have the Ray Tech. We didn't do any local yet, right? Let me do some local first. Why do we use local? Because it's hemostatic. It actually has epinephrine, right? And it stops any kind of little bleeding in the skin. Plus, it also reduces pain with the incision, because we are going to make a scalpel incision here. Even though it's a small incision, it's still an incision, and incisions in the skin do cause pain. Even though you're not awake, subconsciously you feel the pain, and your body responds with increasing heart rate, increasing blood pressure, which we really don't want those kind of fluctuations. So even if you're just doing a skin incision with a patient asleep, we still do local. So that reduces the amount of stimulation shot to the cardiovascular system. All right, now I know this is a big herniation at this level because I could see it on the MRI, but you can also see that the dye has come out and it's kind of going back behind the disc into the spinal canal, but it doesn't really represent how big the herniation is. I know it's bigger than that, bigger than what we're seeing with the dye on the X-ray right now with the discogram. But that said, I don't need to see the whole herniation with the discogram. I know it's there based on the MRI scan. Now this is a Deuk laser disc repair procedure. And look at the pressure in the disc. Watch this. It was actually pushing my guide wire up. Shot. Impressive. So we're going to place the guide wire, and then we're going to take the needle out. So everyone agrees we're at 4-5, correct? We're right above the fusion. It's pretty obvious with the screws and the plate at 5, 6, 6, 7. So she traveled all the way from Texas because she did not want another fusion. And folks, this is why I tell you, don't get fusions. Don't get artificial discs even. People with artificial discs have the same problems. They market it as you don't have as much adjacent segment disease, but it's not true. The people with artificial discs do get adjacent segment disease, and it's definitely, in my opinion, as common. And it was actually that artificial disc disease, adjacent segment disease, that made me start thinking maybe there was more to it than just fusion as the cause of adjacent segment disease. Of course it is, because if you're doing an artificial disc and you get adjacent segment disease, why would you if you're doing an artificial disc? Shot, you're not doing a fusion. So you can't blame adjacent segment disease on fusion. Are you okay over there? All right. So I'm just talking about this whole concept of adjacent segment disease in the context of spine surgery. And the reality is adjacent segment disease exists because of the fact that it already existed and the surgeon didn't treat it the first time. That's the vast majority of adjacent segment disease. And then there's adjacent segment disease because the surgeon basically did not fuse the spine in good alignment. Now, when I look at the alignment on this fusion, it looks pretty good. She's got lordosis, which is what she's supposed to have. Let's get an AP. So I'm happy with her fusion alignment. I don't think that's why she developed adjacent segment disease. I think she probably developed it because it was already there when he did the first fusion and just didn't treat it. And now it's worse. Perfect. Lateral. All right, moral of the story. When you go to get your spine surgery done, ask your surgeon to fix all the discs that need to be fixed so that you don't have to come back and have more surgery later on. And moral number 2, don't get fusions done. Come and get the endoscopic surgery because there is no fusion. You won't get adjacent segment disease. All right, I'm now at the front of the C4-5 disc with the dilator, and I'm going to advance my dilator into the disc. Shot. That's it? Yeah. I don't want to advance the guide wire, so I want to make sure the dilator is not pinching the guide wire. I can feel the bone spur that's in the front of the spine. Shot. We're not treating the bone spur in the front of the spine because it doesn't need to be treated. Can you give me some inline traction, please? Let me know when you're ready. So slight extension to traction. Slight extension with traction. Shot. That's pretty good. I guess she still has earrings on? Or what is? Oh, that's my anesthesiologist rings. Nice. All right, shot. Okay, that's good. You can relax now, doctor. Yeah, thank you. So we're going to continue to advance the dilator through the disc. Now this surgery is called transdiscal because we're literally going through the disc. Trans means across. We're through, and we're going through her disc to get to the herniation in the back. So why are fusions necessary? Fusions and artificial disc surgeries are necessary because the surgeon, to get to the back of the disc, first has to remove all of the disc in between the bones. And so they're left with a gap, basically a big open space that can't be there. So you got to put something in there. So you either put a cage, you put cadaver bone, or you put an artificial disc. And that's been the problem with traditional spine surgery in the neck, is that surgeons have always taken the whole disc out just to get to the little piece in the back where the problem is. And that's why endoscopic surgery is so much better. I did not pioneer the first transdiscal endoscopic cervical surgery. That was done probably by the South Koreans. Nobody really knows for sure who did the first one. But what I pioneered was the technique where we debride the annular tear at the back of the disc. And in doing so, we eliminate the neck pain and headaches and arm pain, arm symptoms called radicular symptoms. Now we are also doing a decompression by removing the herniated disc in the back. Can you give me some slight traction again? Just for like a minute. Let me know when you're traction and extension. Shot? Yeah, that would be helpful. Shot? Because the disc is pretty collapsed. Shot? I think that's some good progress there. Shot? Almost there. Just hold on for one more minute. I'm going to advance the dilator. Shot? Shot? Looks brutal, but it's actually a very calculated maneuver that I'm using. Shot? I'm trying to get my tube right to the back of the disc where that herniation is. And that should be good right about there. All right, we're done. Thank you, doctor. So we'll take the dilator out, and now take a look, folks. I know we've had some people interested in endoscopic surgery in the neck for herniated disc in the cervical spine, but this is it. Okay, you can't see her jaw, but her jaw is up here, her face is here, she's intubated, she's asleep. Thank God she's asleep, because she wouldn't tolerate this very well if she was awake. Now, one of the differences between me and the Koreans is that I put my patients for this type of surgery completely asleep under general anesthesia. Why? I don't want my patient moving around. And the Koreans keep their patients awake, and they move around a lot. I've seen them. And that's how they've gotten some complications with these surgeries in Korea. They've had a few people paralyzed from the surgery. I have had 0 paralyzed from my surgery because they're not moving. And I'm very careful with what I do. But just keep that in mind. There's only a couple of surgeons in the world that do anterior cervical transdiscal surgery. Probably less than 5 in the world. But I am one of them and the only one in the United States. And more importantly, I'm the only one that knows how to cure the neck pain. That's because, and believe me, it's no secret, I tell everybody, we actually repair the annular tear by debriding it. So through that process of debridement, hey Luis, I need you to get me more of these scopes. I know, but I need you to actually succeed. Don't work on it. Finish working on it. Are you ready? What are we 1 seconding? Is there a reason I'm waiting? Tell me. Huh? All right. Almost there. Oh boy. You got to have that ready sooner so we don't have to wait. There's a piece of herniation there. See if I can grab it out. All right, you want to show our viewers what's going on here, Diego? Show them the endoscope.
Yeah, they're watching it.
All right. You guys see this is the endoscope. We call it the endoscopic rig. And we've got irrigation, we've got a light source, camera, which is high definition. We have the actual endoscope, which is fiber optic, not rod lens. We've got 3 ports of access and a laser fiber going down the middle. Once again, I developed this technique. And we call this surgery the Deuk laser disc repair. We have peer-reviewed and published it. We're the first to do so. So it is totally FDA approved and peer-reviewed and published in the National Library of Medicine. You can see where the dilator was, right up against the end plate there, that little hole. But the tear that we're dealing with is right, it'll be more evident in a minute. It's literally running up and down. Maybe you guys can see that. And my tube is kind of stuck. It doesn't want to move because there's so much scar tissue back here from the inflammation. Okay? So I'm going to have to spend a little bit of time just kind of going back and forth and releasing the scar tissue, the herniation, and just getting some movement back into this disc. Because if I can't get any movement back into the disc, it's going to be hard to fix the whole problem. It's going to be hard for me to gain access to all the areas I need to. You see the tear down there at the bottom? I'll show it to you again in a minute, but that's the tear in what's called the posterior longitudinal ligament. And that's the part that's kind of bleeding down there. That's the PLL. There's a herniation right there. And I'm going to sit here and basically remove herniated fragments from the back of the disc. Okay? And then I might actually go past the PLL because this patient definitely has herniated fragments in the epidural space. We call that an extrusion. She's definitely got extruded disc here. So I'm going to have to go down there and get up close and personal with my laser and my endoscope to the actual tear and try to remove pieces of herniation from down there in that little hole. Okay? And you have to do that super careful. I'll show you how to do that in a minute. First, I'm going to clear out the herniation that is what's called subligamentous herniation. It's herniation under the ligament. This stuff's pretty safe and easy to do. As a matter of fact, most cervical disc herniations are subligamentous, and they still cause symptoms. Why is this light on right in my eyes? Can we turn this light off, please? Is that all right? Thank you. Sorry if that affects your view, but I got to be able to see what I'm doing. All right. So this is all, well, nice, subligamentous disc herniations. Any questions from our audience?
Yes, our first question comes from Facebook.
That's
A
great.
viewer asks, if your herniation is too large for a microdiscectomy and fusion and or artificial disc, were only two options given, is it possible to have the laser surgery?
Yeah, so there's great question. The question, I think I understand it to be, if your herniation is really too big, can you still have the laser surgery? The answer is yes. I have not found a herniation I can't remove and give the patient what they want, which is the elimination of their symptoms. Now, there are situations that are not common where herniations actually move up or down the spine after they come out, right? So if you think about it, what I'm doing right here is I'm fixing a herniation that is right behind the disc. There it is. There's a piece of the herniation right there. See that? Bam. Pretty cool. And it's scarred. That's why it hasn't floated up yet. So I'm going to go grab it if I can. But the point I'm trying to say is that a herniation is basically the jelly squeezing out. Now, in the best case scenario, it squeezes out backwards. And I can go through the disc and I can get it because it's just in the back of the disc. But sometimes, I couldn't get it. Sometimes it actually goes backwards and then it goes up underneath the ligament or down. And we call that a migrated disc herniation. Now, migrated herniations are harder to remove, but they're not common. So I guess my question to the person would be, how much of your disc has migrated to areas that are not possible to reach? And in all my years of doing this, the number of severely migrated discs is very small. There aren't many of them. So I would like to see your MRI, and I can tell you for sure. But you need to submit your MRI with the actual images for me to look at. This is all part of the herniation. It's all scarred here in the back of the disc. And I'm just debulking it. We call it debulking in surgery. I'm removing the mass of the herniation, like one layer at a time, using the laser. The laser, by the way, for those of you wondering, how precise is it? Well, look at that herniation right there. That thing is huge in the foramen. That is on her right side. That's probably causing a lot of her arm symptoms right there. That thing is massive. And it's scarred right here. It's stuck. So I'm actually breaking up the scar tissue with the laser. That thing is going to be free soon. And it's going to pop out. And it's going to be really cool. And it's sitting right on the nerve root. So I just got to be careful not to go too deep. Yeah, I'm going to try to grab it out, okay? Because it'd be safer for me to do that if I can grab it out than try to use the laser right now. If I can just get a piece of it, it's like a piece of wet cotton just stuck down there pushing on the nerve. And I don't think I got it. Try again. I don't think I got it, but let me go look. I don't think I was able to get it. So I may have to just laser it out. All right, let's see here. So the laser fiber is half a millimeter, 0.5 millimeters, okay? Half a millimeter. I think it's going to come out in just a minute. It looks like it wants to come out. It is moving and shaking. Look at that thing. It's huge. All right, I think I can get it now. That's a herniation. That's what, now notice I'm in the back of the disc, literally the back 5 millimeters, not even that, 5 millimeters, maybe a couple of millimeters of the disc. And I am pulling out the herniation. Oh, I felt it come. It must have fallen off. It's like so big it doesn't want to come out. There it is. There it is. Okay, take a look at this. Turn the light on. All right, this is just one piece of the herniation, but it's a good size one. Can you guys see this, Diego? Right there?
Yeah, we see it.
That is herniated disc. And look at the pinkish color in there. See that pinkish color right there? That is inflammation. And that's right on the herniation. Okay, that's because her body is getting inflamed from the herniation. It causes inflammation in the back of the disc. That's what I fix with the laser surgery. It's the only surgery in the world that fixes that is the Deuk laser disc repair. Because that's what I'm specifically targeting, okay? Anyway, the laser itself is 0.5 millimeter, okay, wide. So that glass pipe is only 0.5 millimeter wide. Now, what's cool is that the beam comes out of the end, again, only 0.5 millimeter, 0.5 millimeter. So the actual thickness of the laser is 0.5 millimeter, and the working distance is 0.5 millimeter. And that's important to keep in mind, because it's not like it shoots around like in Star Wars where they shoot laser guns and things and they go across the room. The laser energy is dissipated in 0.5 millimeter distance. And the reason for that is this liquid that we have it in. There's constant irrigation going on in here. That's that stuff. It's water, basically. It's saline. There's still another giant herniation right there that I got to deal with. And it's literally sitting right on the nerve in the foramen. So I got to debulk it. It's all scar tissue right there. And I got to fish that thing out. Either fish it out or break it up into little pieces. And to me it doesn't matter, but I like fishing them out better. Oh yeah, wow. That was a blow up. So that is the herniation. And it's big. It's in many pieces. So we're not going to get it all with just one. There's another big piece. But you can see this is a process. It's not one and done. Get in, grab it, get out. You got to get all the pieces out. So I've been doing this long enough that I know 99% of the time there's many pieces, more than just one. And I got to get them all, or the patient won't be fixed all the way. That's a bone spur right there. We saw some bone spurs on the x-ray, right? So why would you want to do this surgery? If you have a herniated disc in your neck, your back, your thoracic region, anywhere in your spine, we can fix it with this laser surgery. And you don't have to have open back surgery or open neck surgery. You don't have to have a fusion. Look at the space down there in the foramen. That's where that herniation was sitting. Right down there. You see that space? It's like a little cave. It's been sitting there so long it's made like a little cave area. Now the reason I was able to get it out is because of the laser. The laser actually jiggles out the herniations along with vaporizing tissue because it creates a pressure wave. We call it cavitation in the liquid going down there. And that pressure wave blasts things like a pressure washer. So I actually have not just the burning and vaporizing of tissues, but also the jiggling that comes along with a good jiggler. Now for those of you who think I'm a silly guy, you're right, I am a silly guy. But you know what? You don't forget the things I say, do you? And that's what it's all about, remembering. You know, when you go to medical school and you got to remember, how many things do we have to remember, Dr. Rafferty? 50 million facts? Huh, right? Literally millions and millions of facts. That's why they're very selective about who goes to med school, by the way. Has nothing to do with anything other than who can remember. And they're very selective. They want people that can remember. So one of the ways we remember, and I talked about this the other day with the pathologists, is the pathologists are always naming things based on food. So they can remember it, right? Well, as a medical student trying to remember everything, we used to come up with silly little things to remember, right? And so you got to have a very good imagination to be a good doctor, because you got to remember so many things. And to remember, you got to have like visualization. I don't know if you all know what visualization means. You all know what visualization means? It's kind of an art form that's lost on the younger generation. Maybe many of the olders don't know. Visualizing means seeing in your mind with what's called the mind's eye. Like I can visualize my house right now. I could see it. I could see the front door. It's closed. It's covered in plastic because we're painting the house. I can see the tape stuck to the edges of the door. It's blue. And the plastic around the door. I could see it all right in my mind's eye. And it's called visualization. So, you know, people talk about out-of-body experiences where you actually leave your body and you go somewhere and travel. And like right now I'm maybe in Italy, in Florence, on the Ponte Vecchia, and I'm haggling with one of those Italian leather smiths who make those coats out of leather, beautiful sheepskin. And I'm trying to get a better price from that person right now while I'm operating. Okay? So visualization. It's very important to learning. Your brain has to store so much information in its little brain. I don't mean that in an offensive way, but all of our brains are pretty damn little when you think about it. Come on, come out. Little piece of herniation there. I'm just going to have to go grab it. Anyway, so your brain needs creative ways, right? We have what are called association cortexes. And, you know, if you think about your senses, right? You have sound, sight, feel, taste, smell. You have these senses, and different parts of the brain are responsible for different senses. So if you can start tapping into your memory centers by associating memories with different senses, then you can actually expand your ability to remember things. How do I know that? Because I'm a brain surgeon, for God's sakes. First and foremost, I had to learn all the brain stuff before I learned the spine stuff. Pretty much at the same time. So, they're called association cortexes. And there are vast parts of your brain dedicated to association cortex, to remembering and associating. Yeah, it's all about memory.
We have a question from Facebook.
Sure.
Has this patient already had fusion surgery?
This patient has already had a fusion, yes. I did not do it. It was done in Texas where they live. And I think they regretted doing it. And now she has problems above her fusion, and she did not want more fusion. So she found me, Deuk Spine Institute, our team, including Luis, and watched our videos just like you are now, and said, the hell with traditional spine surgery, it sucks, I want something better. And then they came here, and now we're doing the next futuristic spine surgery right here in the Space Coast of Florida. Yes, she had a fusion done at 5667. All right, so that's the posterior longitudinal ligament fibers right there, and I have to inspect that area a little bit more I don't want to leave any herniation behind. So I feel like I've gotten a lot of the herniation, but I want to check through that little crack there. But I'm not ready to do that yet. I need to clear away a little more of this stuff on the top. What I'm clearing away, this is the annular tear. So the annulus ends, and behind the annulus is the posterior longitudinal ligament. And the PLL is those white fibers there. And below that is the spinal cord, the dura. Okay? We call it no person's land. No man's, no woman's land. We don't want to go there. But I need to make sure I'm not leaving anything. Pretty cool view, huh? This is a fiber optic scope, for those of you who don't know. Fiber optic scopes are not as good in terms of their visualization as is a rod lens scope. But I don't like the rod lens scope because the rod lens scope is too bulky. And now I'm passing through the PLL with the laser, and I'm looking. I'm trying to figure out, I want to look south. Trying to figure out if we have any herniation down there. Let's see. Uh-huh. Of all the things I do with lasers and scopes, this is the hardest. Right here, right now. Because you're operating on top of the spinal cord, and you really want to make sure you get everything you can. It looks like there's just a lot of scar tissue there. Okay, right in the middle. And almost looks calcified, you ask me. Some calcium down there. All right, we're just about done here at this level. I want to look a little bit more. Now, our job is not to decalcify the posterior ligament. Our job is to get rid of her pain and decompress the spinal cord and nerves. So, you don't want to get too cute and gild the lily. There's definitely an opportunity to get a little bit more of this stuff out safely. But it is stuck down. So we just have to be really careful now. The spinal cord is no longer compressed. We've removed everything that was pushing on it. There's a little bit left stuck to it, but it's not compressing it. So this is where you have to really use good judgment. I've decompressed the spinal cord here. There's a thin layer of scar tissue on top of the dura, and I feel like we've gotten everything we can get out safely. When I look over at her foramen, on the right side. The foramen is decompressed. There's nothing in there. We've gotten all those herniations out. So we're done. And this is where, you know, the experience comes in of knowing when to stop, because somebody who doesn't know what they're doing, which is 100% of the other spine surgeons in the world when they do this because they've never done it before, they don't know when to stop. And knowing when to stop is so important to avoiding complications. Where's my needle? Questions? So, Diego, if there's no questions, why don't you run a video real quick on the cervical Deuk laser disc repair procedure. This is kind of a narrow needle. It's too narrow. It should be saved for the discogram.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Look at me, doctor. So kind of pulling straight back, but slight extension. Give me a countdown.
3, 2, 1.
Yeah, get in here, Jordan. Okay, so hopefully you've watched our animation and you understand what we're doing here. We're debriding the annular tear, removing the herniation that's stuck in there, and in this case, we're decompressing the nerve root and spinal cord. So everyone else that does spine surgery does decompression. We do a decompression and the annular debridement. And we do it all without doing open surgery. It's minimally invasive. So there's no need to fuse or put in metal discs or anything. We're done with this disc. We're going to go to the next one up. The next one up is not as bad of a herniation, but we're going to go up and repair it because I think it's causing pain. So I'm going to leave my dilator shot. Dilator stays in the disc. Tube comes out. We did the whole surgery through this tube, by the way, in case you didn't know. Take a look right here. You guys see this tube? Looks like a little coffee straw. Okay. That whole surgery was done through this tube. Anyone got a mochaccino? Just kidding. All right. Shot. Let's see where we are. All right, so you're just going to keep that fluoro there. That's perfect. And I'm going to move this north. I need that wire out of the way. You got to be watching. Don't let that fall. You got to. This loop is blocking me. You got to pay attention. All right. You guys ready? Here we go. Little traction, extension. Just hold it. Shot. Coming out of the disc. Shot. Shot. Everyone stay where you are. Let's see where I am. AP, Coker. Watch your hand. He's going to bring that up. He doesn't want to hit your hand. Lower your hand a little bit. Feel like I'm off to the side. Let's see. I think I'm on your side. Shot. Just a quick AP, buddy. This is not a Mona Lisa. Come on. Get that right. Yeah, I'm a little bit off to your side. I'm going to come back to my side. Shot. That's good. Shot. Lateral. Don't move. So I'm going to use AP and lateral views. You're too high. You're way too high. All right. I'm going to go a little bit further. Shot. Shot. That's perfect. AP. So I'm now over the next disc, and I'm going to get another shot just to make sure that I'm not off the spine in the midline. I want to be in the middle of the spine. That looks pretty damn good. Let me move it a little bit towards me. That feels really good right there. Don't move anybody. Shot. That's a little too much. See that shot? That's a little too much. Shot. Perfect. Lateral. Take. 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 Are you ready, doctor? Mallet. Thank you. Whenever you need to do something delicate in the spine, you grab a mallet. Shot. I need to be a little lower. Shot. Shot. That's better. AP. Poker. So again, I'm just positioning my tool to where I can enter the next disc safely in the middle. That looks good. I'll just aim it a little to the right. Uh-huh. Shot. I feel it going in. Shot. Nice. And I kind of let it go where it wants once it's in the disc. It follows the path of least resistance. Take. Pipe cleaner. We'll still do a discogram because I want to stain the herniated disc blue. Shot. Take. A lot of fuzz on the end. Can you wipe? Thanks. Still some there. Good to know I can still get it in the hole. Shot. There's the tear. Take. All right, we've lost, what, 5 drops of blood. So we're at 1/4 of a milliliter. Mallet. Can you imagine doing cervical spine surgery with 1/4 of a milliliter of blood loss shot? I don't have to imagine it. Shot. We're just about there at the back of the disc, and it's beautiful. Absolutely beautiful. Now, this is a masterpiece. Look, I get the Mona Lisa and all, David, all the great works, but this is incredible. This is music for your eyes. Basically, we're taking an old surgery fusion, metal plates, cages, screws. You're done, thanks. And we're transforming that highly barbaric, invasive, damaging, scar tissue forming, bloody, painful, crazy surgery into a very elegant outpatient procedure. And if you don't watch this surgery and realize the potential that it's going to have in the world of spine, and you can't see, it's the same thing. When I do this surgery, it's the same as when I got my first cell phone, or I first saw a cell phone, and I realized all those big bulky phones that we have at home are going to be gone someday. Or the first time I bought a digital camera, I actually bought the first digital camera. It was commercially available, the Nikon Coolpix. I bought that back in 2000, maybe 98, 99, I can't remember. Maybe not, no, it was before that. It was about 98, I think. I bought one of the very first, if not the first, digital camera. It was called a Nikon Coolpix camera. And there was no film to develop, none. And everybody else had SLR cameras, and they were all developing film. You know, you take your film to Kodak, and they would develop it. And it was chemicals and nasty, and it took forever to get your pictures. And I bought that Coolpix camera, and I could upload my pictures immediately to my laptop. And I was like, this is going to change the world. Digital pictures. And now who has a SLR anymore? Nobody, right? You know, you're going to see pictures like, look at this. Anybody know what this is? It's an old camera. So this surgery you're watching is literally going to change the world of spine surgery. Shot? Because once people figure it out, that they're not going to want fusions anymore. Shot? Shot? Oh, it's painfully slow. Take that away. All right, so I need to advance this tube. And shot. And I'm not doing a very good job of it. So I need a dry, there we go. Now you're going to have to clean this out, okay? Shot. All right, doctor, I lied to you. I need you to, let me see. I'm making a little bit of progress. That's actually a good one there. I was going to say I may need some more traction, but I'm actually making progress now. I do want to get it back a little further. Hold that. Hold it just like that. Don't move it. No, don't take it away. I said hold it. You have to follow instructions. What I meant was hold it. Let's try this again. Give me that. Okay. Shot. All right. When I say hold it like that, it means hold it. Don't move it. And I will come back for it. Okay? All right. So I think we're pretty close to being done. So just like the digital cameras came and took over, just like the cell phones took over and there's no more pay phones, there's no more home phones, so will this surgery take over all of spine surgery, and there will be no more fusions done and no more artificial discs done. But the people who do the surgeries have to stop doing the bad surgeries. That I can't fix. 9, Fräulein. All right. We're done. We're going to go to the back of this 3-4. Now I've done 2 3-4 discs. 3-4 is a C3-4. C3-4 herniations are not common. They're rare. We don't see a lot of them. I mean, they're not common that they cause symptoms. But in this patient and the one I did on Tuesday from San Francisco, they do cause symptoms. So it actually is, for this week, C3-4 is common special, but normally you don't see C3-4 disc herniations that need surgery. Are you talking to me? I could not hear a word you said. Oh, thank you. By the way, our first patient, they should have sent her home already. All right. Why am I getting no irrigation?
We have a question when you're ready.
Yeah, sure.
All right.
There's a tear, by the way, that blue line.
Alright.
That blue line is the tear. The white thing is the annular tear, the annulus that's torn. The blue stuff is the herniation. Stuck in the tear, called the interposed herniation. But go ahead.
We have a YouTube comment that says, have you ever reviewed anyone's MRI and advised them to get a fusion?
I could not. Again, Diego, you love trailing your voice off.
Can you hear me right now?
I hear you now.
Okay. The comment reads, have you ever reviewed anyone's MRI and advised them to get a fusion?
To get a fusion?
Yes.
Yes. Yes, I have. Have I ever reviewed anyone's MRI and advised them to get a fusion? And the answer is yes, I have. Oh, look at that herniation. Did you see it come out? That was pretty cool, huh? Yeah, but very rarely. But yes, for sure. There are going to be some people who would be better served with a fusion, but probably 1 in every 100. So think about that. 99% of the time, the laser surgery will be what they need. Yeah? All right, let me give you an example. Anybody know what they did for patients that had narrowed coronary arteries and were at risk of having a heart attack? What do we used to do 30 years ago? Anybody know? Not open heart surgery, but revascularization surgery. The surgeon would literally take a graft from your leg, a vein graft, and they would attach it to your heart arteries through literally heart surgery, okay? And then someone came along and figured out we could go in your groin and put a stent, which is a little metal like channel. We can go in your groin and put a stent in. And then you don't have to have the open heart surgery, basically. Okay? You don't have to have reperfusion surgery. You know what I'm saying? So there was a less invasive, very, very successful procedure. So it eliminated 99% of coronary cardiac revascularization surgeries. And people get that done nowadays instead of open surgery, where they crack your chest open and take your heart. And I used to have to hold the heart for those as a resident. That was the job of the resident, to go in there and hold the heart while the surgeon sewed the veins into the arteries so they could revascularize the heart. So this is no different, you know. It's not going to get rid of 100% of fusions, but it sure is going to get rid of most of them, if not 99% of them. Okay? By the way, in case you're wondering, I actually I get more money, I get paid better for fusions. A lot better. So, from a financial standpoint, surgeons do much better doing fusion or artificial disc surgery than they do laser endoscopic surgery, like me. So, you know, it just comes down to doing what's best for the patient. And fusion is never better for the patient unless it really is better for the patient. But if all you know how to do is fusion, and you're a spine surgeon, all you know how to do is fusion, then that's all you're going to recommend. That's how I was for years. You know, even when there was artificial disc, they really hadn't been FDA approved. They were just starting out. And we would not really recommend them because they were too new and we didn't have good long-term data in the United States. But now we have better long-term data on artificial discs and fusions, and we know that they work when they're done properly. The problem is why do you want to have such an invasive surgery done if it's not necessary? Why would you want to have open heart surgery done when you don't need it, when you can have endovascular surgery done instead? Why would you want to have your aneurysm, why would you want to have brain surgery, open your skull and clip an aneurysm when it can be done with a coil or a stent and a coil? Why would you want to have AVM surgery where the surgeon can kill you from the surgery when you could treat the AVM with glue through a catheter? So the point is, there's always advances in the world of medicine, and they always start somewhere. Okay, they don't start everywhere at the same time. By the way, these are all little herniations coming out of the foramen, in case you weren't aware. That's the nerve down there. Okay, so there's not as much herniation on this disc as it was on the last one. So we're not going to be getting as many big pieces out as we did last time, but we will get a few, and I think we've gotten most of them already. Okay. So I'm just cleaning things up. We're just about done. Doctor, we need a few minutes. I talked to one of my friends about the post-op nausea. Yeah, he said that he uses Decadron, and that he gives 5 milligrams. Yeah, 5 milligrams. He said it comes as a 10.
Comes in a 10 and a 4.
And he said, well, 4. You can do 4. He said 4 or 5. 4 or 5.
Okay, we do that.
Yeah. And he said he does it at the beginning of the surgery, I think.
Okay.
Can't remember. And also he said that he gives Zofran, like you do.
Always.
Huh?
Always keep it.
Yeah, yeah. And he always tries to switch from the gas to the propofol near the end. And you weren't giving any narcotics, right?
Just a little bit of fentanyl
Yeah, but at the beginning.
at the beginning.
But that shouldn't be causing, there's some more herniation. Shouldn't be causing the,
I read something, an interesting article. It suggested they had good results with 2 milligrams of Versed about a half an hour before wake up.
all right, well, let's try it.
And I'm going to use this Sucramandex instead of the Neo because the Neo reversal is
Well, why do you have to do any reversal?
vomiting.
Oh,
Pardon?
no, you shouldn't have to do any reversal.
I thought you really liked the paralyzed to pretty much to the end.
No, the very beginning.
Beginning?
Yeah.
Okay.
Yeah, the Suba is very expensive.
Okay.
No.
Okay.
Don't start getting, we did that before, and we were spending ridiculous amounts of money.
Okay. Well, I'll tell you what. Would you mind giving me a heads up when you're okay with your relaxation?
It's basically just in the beginning, I need just a good relaxation.
Okay. So once you get your trocars in, you're good.
Yeah,
Okay. Gotcha.
yeah, I'm good. You don't need, you can let them wake up
Okay.
and just use neostigmine, right?
No neostigmine.
You don't want to use neostigmine?
No, that makes them sick.
That makes them sick?
Oh yeah.
Like nausea?
Yeah.
I didn't know that.
Nausea and it's highly allergic also.
Really?
I really try and avoid it.
Well, you learn something new every day. Do you have any more questions, Diego?
Yes, we have a follow-up from the first question of the day.
Okay?
The person said his herniation was too big. He asked the question because he says that his doctor said his herniation was too large for a microdiscectomy and that there was no other option.
Yeah, you got to understand, people are saying their doctor says there's no other option. You're right. Their doctor doesn't know how to do this surgery. That's why there's no other option. If all you have in your toolbox is a hammer, then everything looks like a nail. But if you've got screwdrivers and you've got other tools, then you start to see the world differently. So your surgeon has no idea this surgery even exists. That's why they're telling you there's no other option. But if they knew this surgery and they actually did it themselves, they would be very happily telling you that this would work. Now again, I'm qualifying my answer because I've heard that answer so many times that, you know, the surgeon tells patient there's no other option. There may be no other option but surgery, but the surgery you choose depends on what's best for you as a patient. But the surgeon is going to choose a surgery based on what they're able to do for you, like what they know how to do, what they're capable of doing. So not all surgeons know how to do artificial discs. Not all surgeons know how to do fusion. So the ones that don't know how to do artificial discs or fusion are going to tell you you need a surgery that doesn't do artificial discs or fusion. You understand? And that's the point I'm trying to teach you all, is that you can't just rely on your surgeon and what they know, because a lot of times that's not going to be the best option for you, the patient. You've got to go out and find what's best. And that's why we do these broadcasts. So you could be aware that there's other treatments out there that are better than fusion, better than artificial disc, better than microdiscectomy, better than laminectomy, but it's not going to be offered by your surgeon. Yeah. So don't expect your surgeon to tell you how great this surgery is when they don't know how to do it themselves. But when you know how to do all the surgeries like I do, then you can actually figure out which is the best and do that. And that's what we do. I do all spine surgeries. I'm not limited in my knowledge or ability. Our surgery center has everything you could possibly need in spine surgery. We're not limited. And if we don't have it here today, we could have it here tomorrow. Oh yeah, baby. That's herniations right there coming out of the foramen. That's what was pushing on her arm, on her nerve to her arm. Sorry, not on her arm, but on her nerve to her arm. And that's pretty much it. It looks good. We're done. So, I'm very happy. The other side of the disc at that level, I got to about the middle, and it was all, there was no herniation on the other side that I could see. So I feel really good about it. Feel like we got everything done we needed to, and I think she'll do fantastic. See how she recovers. But this is an outpatient surgery, in case you didn't know. Okay, these people all go home. Just leave it there. They go home the same day. They all go home today. We've never had to admit a single one of these patients. It's very minimally invasive, as you can see. And this patient will be ready to go in about an hour. This patient has had a history of post-op nausea, vomiting, so we're just going to have to see how she's doing in an hour from now. But that's why we were talking about the nausea stuff earlier. All right, I'm going to take this tube out, put a little bit of pressure on the incision, and then I'm going to show you how we did the surgery. Pull the tube. So let me have that. Let me have that tube. Diego, have you run the comparison video between Deuk laser disc repair and fusion?
It will run during the break.
All right, so in a minute we're going to show you a really cool video side by side comparing what it looks like to do a fusion, ACDF fusion, versus a Deuk laser disc repair. But right now, the whole surgery was done through this tiny little tube. See that? Why are my fingers looking black to you? Because I'm wearing a special glove that is full of lead. It has lead in it, and it basically reduces the amount of radiation from the x-ray machine that my fingers get, so I don't develop sarcomas or tumors on my fingers, a couple of years from now, because I'm doing so much of the surgery. So they are radiation gloves, and they help protect my fingers from the radiation. But here, take a look. The whole surgery was done through a tiny little incision. I'm going to apply pressure for another minute. Just have a little bit of venous bleeding. Not a big deal, and then I'll show you. But her chin is right here. Her face is here. She has a tube coming out of her mouth, and she's asleep. How's blood pressure? Good?
Coming up now. She's
Yeah, it looks good.
90s.
That's fine.
I didn't even have
But
to
she's
do
not
anything.
hypertensive.
No, she started at 100.
All right. So I'm just going to apply pressure for another minute. It usually takes about 5 minutes before venous bleeding stops. That can be affected, of course, by medications the patient takes. So they take aspirin, Even if you stop aspirin a week before surgery, it still has an effect on platelet function for about 30 to 45 days. So if you really want to get rid of the aspirin effect on your platelets and bleeding, you have to stop for at least a month and a half to 2 months to be sure. But it definitely has an effect on platelet function. Remember, your platelets are the first thing your body does when it has a tear in a blood vessel. Platelets are floating around in your bloodstream, and they come together and bind to the exposed tunica adventitia, which has a lot of interesting molecules in it, like collagen. They bind the platelets, and then the platelets start clumping together, and they form a little plug that plugs the hole. So that's the first step in clotting, is the platelet plug. If you don't have the ability to make platelet plug, you're going to bleed longer. Your bleeding time is long. So that's why we ask all of our patients to stop anti-inflammatories and any kind of medications or drugs that would affect their bleeding. So let's see if we can get a good view here of our surgery site. Let's keep our blood pressure controlled. I don't want her spiking. So looks good. No bleeding. You guys see this incision right here? It's literally 4 millimeters. So incredible. Do another 2 minutes just to be 100% safe and sure. I'm going to come and answer questions. Go ahead and show our audience the difference between ACDF surgery and Deuk laser disc repair, what we just did.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc.
And one.
Okay, they're operating on my brain, as you can see. Take off the hat.
There you go.
I was having a bad hair day, but you know what? That's all right. I am Dr. Deukmedjian, the CEO and founder of Deuk Spine Institute, and welcome to our broadcast live from the operating rooms at Deuk Spine Institute, where we do spine surgery lively broadcasted around the world, free of charge, and we answer all your questions if we can. So the purpose of our broadcast, once again, is to show everyone around the world the truth in spine surgery, whether it's fusions or artificial discs or endoscopic spine surgery, laminectomy, microdiscectomy, you name it. Somebody had asked during the surgery, do I ever not recommend endoscopic surgery? The answer is yes, but it's extremely rare. I had a case with a patient yesterday that he has actually in his lower back, he's got so much arthritis. I'm going to show you where the arthritis is. If you look at the spine here, I want you to notice this hole right here called the neural foramen. You see that? Nerves come out of there. And he's got pinched nerves right in that hole. But his nerves are being pinched not from a disc herniation, which most people are. He actually has these huge bone spurs coming off his facet joint back here. And they're growing into the foramen and literally obliterating the foramen. They're just crushing the nerve root. So will the laser work for that? No, it won't. And what I told him he needed to do was a laminectomy. Yes, heresy from my mouth. But the truth is that not everybody can do the laser. Only about 99% of people can. The other 1% have a condition of the spine that really doesn't lend itself to being repaired with the laser endoscopic surgery, which is really geared towards disc herniations and annular tears. So we'll be doing, if he agrees to it, we'll be doing a 2-level lumbar laminectomy, L4, L5, S1, and I will be using metal instruments to go around in that hole and bite out those bone spurs to make more room for the nerve roots so that we can get rid of his leg pain. This gentleman can barely walk. He can't even get to the mailbox anymore. He just, as soon as he's standing up, he's getting horrible leg pain. And he's bent over because anytime he stands straight, it puts pressure on the nerve. So yeah, sometimes people do need more invasive surgery, but I can tell you right now, there are every 100 invasive surgeries being done in spine with fusion or screws, rods, artificial disc. 100, we could probably eliminate 98 to 99 of them with the laser surgery. All right, what's our first question on this patient we just finished up with?
Cool. It's the guy from YouTube who was asking about the large herniation. He says he's really excited. He's been watching all morning. He just submitted his MRI and filled out his form. He just wants to know how long can you expect a review.
So great question. One of our viewers submitted their MRI for review. How long does it take? Normally it takes me just a couple of days to do the review because remember, I do a lot more than just sit around waiting for reviews to be done. I actually run an entire company. We have 70 employees here at Deuk Spine, and I got to run the surgery center, the clinic. I have doctors working for me. I'm the CEO, so I got all these administrative tasks to do, which believe me, I would rather offload them and just focus on medicine because that's why I went into medicine. I love taking care of people. But those administrative tasks take my time. So generally 2 days to 3 days, and Maya will be in touch with you. However, next week is exceptional. I'm going to be gone. I'm not on vacation. Contrary to popular belief, I'm actually working. I will be in Europe with my son who's racing professionally, race cars, formula cars. He will be racing in what's called the Formula Regional European Championship in Mugello, Italy. He will be representing the United States of America. I think he's the only American driver there. So hopefully he'll represent our country well, but I got to be there to take care of that young little buck because he's only 16 years old. So I will be gone next week, but I will be back the following week. So I will probably get the MRI review done tomorrow before I leave. I'm also here on Monday. When will we do our video conference face to face? I don't know. I know that I have video conferences tomorrow pretty much all day. So if I can get your MRI review done today, I will, and try to squeeze you onto our video conference schedule tomorrow if you'd like. Maya should be in touch with you. Just be real nice to Maya and tell her Dr. Deuk said over the internet that he would do your MRI review today and try to squeeze you in for a video conference tomorrow. How does that sound? Would you like that? Less than 24 hours turnaround? I thought you would. All right, well, is that our only question?
Another one.
We have one more
We have
question.
some guy from YouTube. He says, I would love to have your services, but lives in Washington State. He's getting fused 3 cervical discs and having trouble with insurance companies.
Yeah, so thank you. We have a viewer who's in Washington State. Absolutely beautiful place to live, in my opinion. I almost ended up in Seattle, Washington for my residency up there in Seattle, which is a really good program. And I'm sorry you're having trouble with your insurance company. I'm going to tell you right now, folks, you have got to fight your insurance companies. They are not taking care of you. They are, insurance came around, and I'm old enough to remember insurance when it was starting up, health insurance years and years ago. My dad was a doctor back in the 80s, 70s, and 80s. And obviously, insurance companies have been around longer than that. But back in the 70s and 80s, the doctor and the patient sat down, talked about what the best treatment would be for that patient. The patient decided with the doctor what the best treatment would be. They did the treatment, and then they billed the insurance company. And the insurance company paid, all the time. They never challenged what the doctor ordered. The insurance companies never challenged the medication we prescribed. They never challenged the procedure. And literally, my father's notes, when he saw a patient, he was an OB-GYN, there were 2 sentences. And that's all he had to do, 2 sentences. Now these insurance companies have made our lives so miserable by demanding literally 30, 40, 50 pages of documentation for every patient, whether or not we're doing any treatment, just to slow doctors down and keep us from actually rendering care. Because when you're writing up paperwork, you're not actually helping patients render care. You're not actually doing what the patient needs done to get better. You're just doing paperwork to make the insurance companies happy. So insurance companies are disgusting, and they are greedy, and they're pigs, and they are literally worse than the devil himself, herself, whatever the devil is. And I'm telling you, I tell you this with 1000% conviction that that is the case. And you will not fix the problem unless everyone unites together and demands that their politicians write laws in your state that prevent the insurance companies from denying your medical care. Insurance companies should not be able to decide if you need surgery or not. They should not be able to decide if you need an MRI or not, okay? And they're able to do that through this policy that allows them to deny payment for your MRI. They will never come and send a representative to stop you from getting in the MRI scanner. By all means, get in the MRI scanner. By all means, get that procedure. They just won't pay for it. So they have the politicians in their pockets, and the politicians write the laws that let the insurance companies say no to anybody they want to, and they are not held accountable, except to you, the patient. And you, the patient, get these letters that your doctors ordered this treatment that's experimental or not medically necessary. What do you think the patients think about their doctors when they see that kind of letter? They think their doctors are idiots. Now, granted, a lot of doctors are idiots. I agree, they are. But the insurance companies are pure evil, pitting the patients against their doctors, making the patients think their doctors really don't care about them. And the reality is the insurance companies on our side have made it impossible almost to get treatments approved and paid for. Okay? So I'm sorry you're struggling, over there in Washington with your ACDF, but I can tell you right now, we have all these people you see that come here. They all have insurance for the most part, and they're paying a deposit. They're getting their surgery done, and we are billing their insurance, and we are fighting their insurance. And we actually have lawyers that specialize in suing health insurance companies for not paying appropriate medical bills. And honest to God, nothing's ever felt so good but to stick it to the insurance companies. They always talk the talk, but they don't walk the walk. Okay? So they'll deny and deny, and we'll write letters like we're supposed to. We'll do everything in their book. And then we'll sue them. And when we sue them, we go in front of a jury. And what do you think the jury's going to decide? You think the jury's going to side with the insurance company that's just trying to slime their way out of not paying for your medical care? Or do you think the jury's going to decide that the insurance company better pay that damn bill? You better believe it. The jury will destroy them. So the reason why people are so afraid of their insurance companies is you think there's no way to beat them. But there is a way to beat them. But it's like David fighting Goliath. There's just one little way to beat them. And there's a narrow path, but you have to do everything right. You have to have the right stone. You have to have the right slingshot. You got to get the right momentum, and you got to hit Goliath right in the right spot to knock him out and then cut his head off. And that's what needs to happen with the insurance companies. I'm trying to lead that charge, but again, I look around, I'm like, where are the rest of the doctors? Where are the hospitals? Where are the other people that I can't do this alone? So the truth is that you have to do it ultimately. Well, you, the patients, have to fight your insurance companies. And you got to do it one at a time. I'm going to tell you one more thing. Artificial discs, okay? Total disc replacement, artificial disc, cervical, lumbar. They were at one time, 20 years ago, they were called experimental in the United States by the insurance companies. The insurance companies didn't want to pay for them. They thought, oh shit, all these people are going to want artificial discs, we're going to have to pay for them now. So they said they were experimental, and this is what happened. Patients went and paid cash. They paid out of their pocket, they paid out of their savings for what they knew was better for them. Then the hospital billed the insurance company, and the insurance company denied payment, okay, saying it's experimental. Then the patient and the hospital got together and they did a class action lawsuit against the insurance companies. And guess what? Now insurance companies pay for artificial discs, okay? And they will continue to pay for them because they know they're going to lose that lawsuit. Same thing with this endoscopic surgery. We just need people willing to stand up and do the challenge and basically take the initiative to get it done. Fight the insurance companies in court and let the American legal system, our justice system, do what it's supposed to do. Okay? That's all I can say. Any more questions?
He says, "Thank you, awesome, and you can't know how relieved I am that I have found you."
Well, I'm glad you found us too, and I really hope that more people do so they learn the truth about herniated disc, bulging disc, degenerated disc, and that you don't have to go through fusions. You really don't. You don't have to go through artificial discs. Those are dangerous, invasive surgeries. The time is now. We figured it out. We have it. We've got endoscopic surgery, and we're not leaving any metal or plastic in your body. We're not putting cadaver in there, and you're keeping the movement of your natural disc. We're just leaving your natural disc in there to do its job. We're just fixing the little part in the back that's bad. Have a nice day. We have 3 more surgeries to go. The next one is a 1-level cervical, C5-6. This patient's had a fusion also. They had cadaver bone put in, I want to say 30 or 40 years ago, through their neck. We're doing the disc above. So it's kind of like this one, but minus the metal plate. And then we've got 2 lumbar single levels afterwards. Grab some popcorn.